Welcome all of you for Shankara Academy of Vision lecture series. And today we have with us Dr. Sandra Block, who is Doctor of Optometry and Fellowship from COVD, Diplomate in American Academy of Optometry in Public Health and Environmental Vision. Also, she is a Professor Emeritus for Illinois College of Optometry. Ma'am, over to you, ma'am, for your topic today. We are enlightened to invite you for this session. Thank you for accepting our invitation.
Thank you very much for inviting me. I'm so excited to be part of the World Sight Day celebration in Shankara. It's really an honor in my mind to be a part of your program. Today, what I'm going to do is talk about patients with intellectual disabilities. And while I have done that before and as a part of the World Sight Day in 2020, I'm going to focus on a few different things today that I think are oftentimes ignored in patients with intellectual disability. During this presentation, I will refer to patients with intellectual ability as ID. So when I say ID, you'll know who I'm talking about. What I want to do is I want to start with the fact that we had the World Report on Vision released in 2019. And there were a lot of things in that report that apply to the population we're going to discuss today. So if you all recall, it said that 2.2 billion people had visual impairment. And the thing that I want you to focus in on is the fact that there was at least 1 billion people that had visual impairment that could have been prevented or still hadn't been identified. This is more the population that I'm going to focus in on today. And as you see on the right side of your screen, there's a number of different situations that we know occur regularly in our populations: corneal opacities, diabetic retinopathy, trachoma, glaucoma, cataracts, presbyopia, and other forms of unaddressed refractive error. These are very common in the population with ID. As a matter of fact, when you start to think about it, we've heard about the myopia pandemic, and we know that of the people who are visually impaired because of refractive error and myopia, 312 million of them are under 19. The question is, what percentage has intellectual disabilities? And we don't know. The other aspect is we oftentimes don't think about people with ID as growing older, as becoming adults. And with that comes along the issues of glaucoma, age-related macular degeneration, diabetic retinopathy, and presbyopia. These things were focused in on the World Report on Vision. What I want you to do is think about it as these patients come into your office, these patients with intellectual disability. You need to think about them as adults in a population that would be at risk for some of these other disease entities. So let's move on a little bit to some of the more common types of problems that we know happen oftentimes in patients with ID. These were also focused in on in the report. We know patients with Down syndrome have issues related to blepharitis and conjunctivitis. We know that chalazions, hordeolums, pterygiums, pingueculas, and hemorrhages are things that we'll see oftentimes with patients with ID. What we don't get to really identify very well is the potential of dry eye. And that's a bit of an issue when we're talking about patients with ID, because oftentimes they have incomplete closure. There is lots of exposure for other reasons to the potential of dry eye, but rarely do we look for it because they're not complaining. So, one too many. Let's look at the fact that the World Report on Vision also highlighted what groups are most likely in that unassessed population. We know that people who are in low and middle income regions are more likely missed and not treated. We also know that people in rural areas, low income, female, people who are the geriatric jet set, the indigenous population, ethnic minorities, and the last bullet is the one we're talking about today. These are the people who are most likely not addressed, and that includes people with intellectual disability or other disabilities. So let's think about it. This is a population that we know is underserved in the eye care community. The research in literature is few and far between when we talk about surveillance for patients with ID. So the most recent one was from 2012, and it talked about the fact from a perspective of systemic health that 51% of the population of people with ID were identified as fair or poor health. They faced a multitude of secondary health conditions, and I'm going to go through a number of those a little later in this presentation. They are 5 times more likely to be diabetic. And as we know, people who are uncontrolled diabetic are more at risk for diabetic retinopathy. Oftentimes, this is a population that is more likely to be abused, and mortality occurs around 16 years earlier, though there are some research studies that are starting to show that maybe it's more 12 because we're doing a better job of taking care of them. But what are some of the barriers to good health that we know? Take a look at this. Now, I, as a faculty member, have always been concerned about ensuring that my students, my optometry students, had some exposure to people with intellectual disability. But there's a number of studies that say that their experience and knowledge of how to deal with this population is insufficient. We need to do a better job of making them more aware of the needs of this population, not only from a pediatric standpoint, but a lifelong standpoint, because this population is aging. We also see this population has a lot of diagnostic overshadowing, which basically says that you think that the problems they're exhibiting are related to their intellectual disability and may not be. Maybe they're losing vision because of glaucoma, or something happened and there's a diabetic retinopathy that has been undiagnosed and is progressing. Their change in behavior are not necessarily related to their ID, but maybe a vision problem. We also know that there's access issues with respect to transportation. There's poor laws or policies that really focus on ensuring that people with ID get appropriate health care, and within that, eye care. We know that the World Report on Vision was really focused on ensuring that we have integrated patient-centered care as well as universal health care, with the idea that we as optometrists will be moved away from a siloed process where we are, in order to access eye care, you have to go elsewhere, but be more integrated into universal healthcare model, which is really where we belong. And we know that there's lots of cultural beliefs and biases that are associated with people with intellectual disability. We have to break some of those attitudes and the discrimination that occurs down in order to ensure they get good quality eye care. So with that, and I've talked about this in the past, what is a comprehensive eye exam for a patient with intellectual disability? And I know you know all these pieces, but I want to focus in on a few things that I think are really important that we oftentimes ignore when we're dealing with this population. Number one, the population is not all a pediatric population, and we need to look at them and ask questions that relate to what is age appropriate. If they are a child, we're going to ask about their academic and their sports related things. As an adult, we need to look at what do they do on a daily basis. Do they work in a workshop? Are they having any difficulties? What kinds of symptoms do they report if they're able to verbalize it? Or what kinds of signs do their caregivers or the people that work with them on a day-to-day basis report to us? We don't want to spend a lot of time on it because we all know that some of our more severely affected patients with ID have very short attention spans. So you start out with a brief history and get a sense of where you want to go, but you need to continue that process throughout the exam and monitor their behavior as you go along. There are some challenges that we're experiencing with COVID. You know, oftentimes people with ID will look at your face to get a sense of how to respond to you. And as we all wear masks, it makes it much more difficult. There are some people who've come up, especially with people with auditory problems, with masks that have a clear center so they can actually see your mouth move as you speak to them. I almost wish we all would have those kinds of things, or the face mask where they can actually read your behavior and your interactions with them so they can respond more appropriately. The next thing I always like to highlight is lensometry is really important to do up front, but you want to know not only the glasses that they're wearing, but the glasses that they received but refused to wear, because you want to make sure you don't make the same mistakes as somebody else. In my experiences, we've had patients come in where the cylinder is 90 degrees off axis, and the athlete has been fighting to put those on and wear them, well, for good reason. We talk about doing visual acuity testing on all our patients. It's sort of the cornerstone of our exam. I always like to reinforce the fact that I want to develop a rapport with my patients. So I always like to start up close first and then move back to a distance visual acuity. And I like to try it binocularly because oftentimes, especially in patients that might have experienced some abuse, that as you come close to them with something, they may back off and you will not get truly a monocular visual acuity level. And use things that don't rely on verbal skills, because oftentimes their voices or their speech may be difficult to understand. Rely on other things. Entrance tests are other things that I don't often talk about, but I think are really important. I've had a number of patients come in that were going to be put in a motorized wheelchair, and doing a confrontation field on these individuals is absolutely imperative, because you want to know that there's no field restriction as they mobilize down the corridor, and they know where the corners are and what's out in the way. I also like to look at EOMs to give me a sense, is there any restriction that would affect their vision? And I'd like to begin my binocular assessment doing an NPC, but using something that's engaging. I always try to have a multitude of different targets that I can keep the patient on target. And if they like letters, super, you got it made. But if they don't, I want to have different things where I could talk with them and keep their attention on tasks. Cover test is obviously important, and you'll do a Hirschberg kappa. But one of the things I wanted to talk about today is this new device called the Blink. The Blink is an automated device that will pick up microstrabismus. And it's relatively new on the market, but it's been around in research for quite some time. And it gives you an opportunity, if you can't get a good test on for strabismus, to assess whether strabismus is present or not. Certainly color vision and depth perception are nice. I mean, they're not the cornerstone of your exam, but they will give you some support for some of the diagnoses you're making. And I like color vision because oftentimes in classrooms, people with ID are oftentimes focused in on colors, and that's how their teachers focus them on doing different tasks. And the same thing occurs in workshops. So it's nice to know if there's a color vision deficit so you don't rely on that. The next thing I wanted to highlight was the importance of a good refractive error assessment. In my clinic before I retired, always had an auto-refraction to give me a starting point, whether it's a desktop model or a Nikon Retina Max. What it does is it gives me an idea of, number one, what the astigmatism is, and number two, a little bit about whether there's any significant refractive error. Keep in mind that sometimes low hyperopes are masked by your autorefractors, because accommodation is not very well controlled in this population. But I want you to understand retinoscopy is the core of doing a good refractive error assessment. Now, the image I have here of Dr. Knuppel doing retinoscopy is designed in a different way, because this is an athlete from my Special Olympic program that couldn't focus on a distant target. So she's doing almost a modified Mohindra technique using tools that she knows that athlete will work with. Keep in mind, these are important. You need to modify your exam to the needs of your patient. The other thing I wanted to highlight today, which I don't usually highlight, is the importance of IOPs and eye health. As you have a population that is aging, you need to look for those different things. You need to rule out glaucoma. And I like the eye care tonometers because you don't have to use any drops in order to get an accurate applanation pressure on these individuals. Certainly there are the Tonopen, but that requires anesthetic. And if they sit in a slit lamp, you're certainly going to do Goldman. But in cases you can't, the eye care tonometer is an excellent opportunity to assess pressure and feel comfortable that it's a reasonably accurate one. And then eye health, I wanted to reinforce that, a good assessment of both pupils, the external, whether it's a handheld slit lamp, a 20 diopter lens, high plus in your ophthalmoscope, or a regular desktop slit lamp are important. And looking at the back of the eye with whatever you can, whether it's dilating them, or if they have a large pupil, you can use your BIO and your 20 diopter lens to look at the fundus, or you could, if they sit in a slit lamp, you can do that. There are lots of ways, but it's imperative that we do a good assessment of their posterior pole, because as they age, we expect lots of things to go on. The other things I wanted to focus in on is the importance of, if you find a prescription, that the glasses fit properly. That means they have to fit the bridge properly. And there's a number of frames that have been designed for people with flatter bridges, such as those that we see with Down syndrome. And those also have the temple set in such a way. The worst thing is to have somebody wearing their glasses down here, crooked, or not comfortable, because then they're not going to wear them. Very important. If they don't wear their glasses, all the work that you put in to get a good refraction is going to be wasted. So let's look a little bit at the issue of the other continuum, the continuum we often don't really focus on, and that's caring for people with ID as they age. Now, one of the things I wanted to point out is the prevalence of chronic vision impairment is strongly age related. This data is not on patients with ID, but it's similar to what we would find in a population. It just may occur a little earlier. So here is our age, the decade of 60s, 70s, and 80s. And I want you to look, this is legal blindness, uncorrectable low vision, but let's look at this last category, all visual impairment. And look at the percentage of visual impairment in the 6th decade, the 7th decade, and then the 80s, which is 23.7. That is significant. That is, as the patients age, we expect to see a higher prevalence. We know, however, that patients with ID are oftentimes aging at a faster rate. So we need to think about those issues earlier on. We also know that as people get older, they have something called multiple chronic conditions. And this was termed by a gerontologist that I know here in the United States. In the US, some of the data that we see shows that 2/3 of Medicare people has 2 or more chronic conditions. Medicare is our health insurance for people 65 or older. And 1/4 of them have 5 or more chronic conditions. That's really significant. And the things that puts them at more risk with these multiple chronic conditions is you see more hospitalization, you see more physical and mental complications, you see more issues of disability, institutionalized, and premature death. These are all things we need to work on to address. And with that, the things that will affect quality of life include, you see more depression as you start to lose your independence. You see more cognitive and hearing impairments. We know patients with Down syndrome will start to show dementia much earlier. So the more dementia you see, the less independent and the more dependent on other people for their care. And what's interesting is you also see issues of falls or balance impairment. And with that, we all know that that's a worry we have of people who are older, as well as people with intellectual disability, because oftentimes their gaits are not very well balanced. There is some data that looks at the life expectancy of those individuals with ID as compared to the general population. Now, clearly COVID has affected these numbers. These are a bit dated, but the general population here in the US is about 77 years as far as the life expectancy. Those people with mild ID, 74 years. Those people who have moderate ID is 66, and people with severe intellectual disability is about 54, which is significantly better than it was 40 years ago. I remember when I used to talk about the life expectancy of patients with Down syndrome to be less than 20 years. So we've come a long way, but we still have a long way to go. Some of the vision problems that we expect in this population are the things that you're going to see in an aging population without intellectual disability. There are issues of cataracts, glaucoma, refractive error, and I'm talking about refractive error that's not corrected. It's not going to be any different than what you would expect as a child. Age-related macular degeneration. There are no good studies that identify the prevalence of AMD in this population, but we know it has to occur. Diabetic retinopathy is a very major cause of vision issues in the aging population with ID. If you think about it, their diets are not very good. Their abilities to stay physically active are not very good. This is a population at high risk for diabetic retinopathy, and certainly dry eye. And I don't know about how many of you do low vision or vision rehabilitation, but we know that there's a lot of visual limitations, and people are not making any recommendations for modifications to their homes, changes using telescopes or other types of low vision aids. We need to think about that. This is a population, as they age, will have the same needs as our regular population. They also have lots of secondary conditions. I talked about it earlier in this presentation that we need to think about it. Why is this population more likely to develop chronic health conditions? Well, number one, we know it occurs younger. Part of it's associated with their diagnosis of which syndrome or developmental disorder or what they were exposed to early in their lives. They typically do not have the same access to healthcare services, which is contradictory to everything the World Report on Vision says. And now we know they have a longer lifespan than they did when we started focusing on this population. We need to think about these secondary conditions as preventable health problems, and not necessarily just limited to their diagnosis, but just overall limiting their abilities to have a high quality of life. And some of these health problems can be physiologic or they can be psychologic. And the assumption based on everything I've been reading is that the psychological impact of COVID has really been significant, because this is a population that has been locked down for longer and longer periods than maybe the regular general public, and oftentimes have harder times accessing vaccines. And there can be environmental concerns if they don't have the ability to mobilize independently or get around the city on their own. The things that I think about, that I worry about with them, is their poor physical fitness, their poor dietary patterns, the fact that there's a much higher prevalence of hypertension, diabetes, or other metabolic disorders. They have more heart disease, either associated with their diagnosis or associated with just the aging process. They have arthritis that in some cases actually presents earlier than you would expect in a general population. And they have a lot of things that relate to more congestion and flu-related conditions or complications such as pneumonia. And I've added COVID with a question mark because we don't know where this population stands with the impact of COVID on their abilities to handle flu-related problems. I work with some dentists, and the number of issues related to oral health are significant. Peritonitis, decay, abscess, and those things will affect the whole body. And the fact is that this is a population that 4 to 10 times more frequent abuse in adults with intellectual disability than the general population. And then they have lots of secondary conditions that are typically related to their ID: bowel, bladder, GI problems, pain, things related to their poor mobility, depression. They have more injuries because of their mobility issues, fatigue, osteoporosis. We know women with Down syndrome will demonstrate osteoporosis earlier, and patients with CP have contractures from early life on. So we want to think about all those things as we relates to their health disparities as compared to a general population. We know that they are more likely to die early. The reality is, when they looked at one study, patients with ID had 2.7 visits to health professionals as related to 3 for men, 5 for women, and 6 for children or the elderly. So this population is not accessing healthcare services as they should. And when you talk about specialties, only 30 to 47% of the patients with ID actually get access to specialists. And of those, 92% of the people with ID 92% have some need to see somebody with a specialty. And then access to mental health services is even worse. Only 25% of the population is actually receiving the needed service that we should suggest. Just to give you a sense of some mortality pieces as compared to the regular population, we know that population with ID is more likely to die from cardiovascular disease that's not addressed, COPD, and other lung conditions. And the data on diabetes is really variable. Unfortunately, surveillance in patients with intellectual disability is not sufficient to really make strong claims, but we know that in a general population, it's between 3 and 6%. In the ID population, people die between 1.6 and 9.1%. We need better research. There's no question. We also need to think about the fact that this is a population that's not stable. We know that they are more likely to fall. And with that, we see oftentimes people dying more earlier as a result of the complications of falls. So these are things that we need to think seriously about, making sure that patients with ID as they get older are in places where they're safe, where the grounds are even, where there's less stairs, where they can access things without worrying about falling. So there are lots of health challenges as this population faces every day. There's a high prevalence of both physical and mental health problems that we see in patients with intellectual disability. The problem is no one's really looked at the quantity and the quality of the services they receive. How many people are actually opening their optometric practices to this population, and what kinds of services are we delivering to this population as they become adults, or even as they become the geriatric population with ID? We need to do a better job. We know that they're susceptible to the same conditions that we treat patients without ID. We also know that sometimes some of these diagnoses have higher prevalences or prevalences that start to show at an earlier time, which means they may end up being more severe. We know that there's more barriers for them in receiving the kind of care we would expect to deliver to our patients. So we need to think about not necessarily just delivering the care. We need to think about how can we prevent the services from being needed and getting those prevention services to the population early on, so we don't see the depth of the glaucoma or the diabetic retinopathy affecting them and their ability to have a good quality of life. So prevention services need to be quality, equitable, accessible, leading to good, comprehensive eye care services. We need to make sure our health profession students, our optometry students know the value of sharing and dealing with this population and how to deal with this population in a way that fits into their practice. So with that, I hope I've highlighted the importance of working with populations as they mature. It is my heart and soul and making sure that people with intellectual disability have the same quality of care that you provide for all of your other patients. So I'd like to thank you for your time and your attention. And I wish you all a wonderful 2021 World Sight Day. And I hope you have a wonderful day. Thank you.
Thank you very much, Dr. Sandra Block, for your presentation on special population evaluation, especially about intellectual disability patients. How do we evaluate? The points such as the disease conditions, what are faced by these special population, and the health challenges which are faced by these special population like intellectual patients was really heart-warming topic, so that we take a point from this. And also you made a point that all the optometry practice should be able to cater these type of special patients. Thank you very much for the information provided. If for the audience, if you have any questions, please put your questions in our chat box. We will be able to get back to your questions. Thank you, ma'am. And for all of you, stay safe and stay healthy. Okay.
Bye, everyone.